This first case article's on the go feature is titled The Elusive Consistency of Perioperative Productivity, written by Paul Wafer, BS, MBA, RN. In order to maximize revenue, today's ORs are striving to reduce hospital-acquired infections, reduce errors, assimilate new technology to further reduce the invasiveness of surgery and reduce the length of stay, while also taking on other new product lines in spine and orthopedics that require a myriad of surgical instrument trays, surgical navigation, radiological procedures, and robotics. At the same time, the Accountable Care Act is causing hospitals to take a very close look at their perioperative operations and to create further cost savings and efficiencies. One of the ways that hospitals gauge the efficiency of their perioperative department is through the establishment and monitoring of a productivity standard. Typically, these standards are based on the hours worked in a department per a unit of service, or UOS. During my time as a perioperative consultant, I was often asked to validate, adjust, reduce, or otherwise re-examine the existing standard. Many hospitals try to meet a benchmark that has been established by another facility within their health system or some other data source. And while this is inherently a good idea, there are some caveats that must be addressed. Apples to apples, or apples and oranges? One of the greatest challenges to matching productivity standards and achieving a benchmark is assuring that you are including and excluding similar roles within a department. I can provide you with many examples, but some of the most common roles that are included in some departments and excluded in others are RNFAs, housekeepers, and materials management. Other potential roles, based on the size of the department, include education, anesthesia technicians, radiology technicians, biomedical engineering, information systems, and pharmacy. All too often, there is variation in what is included within a hospital-specific standard, and they are trying to achieve a benchmark that historically does not include the additional roles. If hospitals truly want to benchmark themselves against the standard, then there should be a national discussion about what should be included and excluded as part of the productivity within the surgery department. The disparity in the definition of perioperative productivity is causing some hospitals to try to put a square peg in a round hole. In doing so, it is adding additional stress and the potential for error in an area that is already a high-risk zone. Volume cures all evils. Anyone who has spent a lot of time working with perioperative productivity will tell you that volume cures all. The reason for this is that typically a standard is based on either hours or minutes of surgery time. The correlation of time to hours worked is a straightforward diagonal line on a graph. The problem is that there are other factors that can impact this equation. For example, how many rooms are running, and are there any holes in the schedule? One OR could have 40 hours of surgery in a day scheduled in 5 rooms, while another may have 40 hours scheduled in 8 rooms. At a bare minimum, the OR with 8 rooms running will need 6 more people for the same volume of surgery, a team of 2 for each room. The reality is that the true graph for OR productivity should be a stair-step pattern based on both the number of rooms and the volume. While it is up to the management of the department to keep the schedule as efficient as possible, the reality is that when a department is trying to grow additional business and fill rooms, there will be times when efficiency has to compete against potential long-term growth. When developing a standard for budget purposes, the hospital must decide what is most important to them, and then back up the OR director when they have to make hard decisions with the surgery schedule. The maturity factor. Another factor that can impact the efficiency of the OR is the maturity and experience level of the staff. In some geographic areas of the country where there are not a lot of hospitals, or if there is a union environment where seniority is a factor, there may be many staff members that have worked in the same department for many years. Staff members that have worked together for many years and are also familiar with all of the doctor's preferences may be able to work very efficiently with very little supervision. Yet other hospitals that have a competitive environment for OR staff may experience a greater amount of turnover, have less experienced staff, and will be less efficient. These hospitals will require greater supervision and resources and may also need to have a modified productivity standard. Development of consistent processes within a department can mitigate some of the issues with the lack of maturity, but developing those processes also requires time and personnel. Minute to minute. When calculating the actual minutes of service, some organizations will use the number of minutes charged to the patient to determine the number. Other organizations will pull the number from the OR information system. Frequently, those numbers will not match. Many hospitals will charge in 15 or 30-minute increments, even if the actual procedure time only goes 5 minutes into the next time segment. This will lead to an inflated number of minutes and may make the productivity look more efficient. It is important when comparing facilities that you know which minutes they are using and the time increment for charging if that number is used. Questions to ask. If you are a hospital administrator with responsibility over the OR, or a member of the finance department developing a budget for the coming year, there are some questions you must consider before determining the productivity standard for your perioperative area. Number 1. Which categories of employees are included in the productivity standard? Number 2. Should these categories be in the cost center of surgery or a support department? Number 3. If we are using a benchmark from another facility, do we have the inclusions and exclusions defined by them? Number 4. Are we projecting a growth in surgical volume in the coming year? Number 5. Where is that volume coming from and how will it fit into our existing schedule or number of rooms? Number 6. If we are not projecting new volume, will we be able to manage the rooms more efficiently without further erosion of our surgery business? Number 7. Are we a trauma center? Do we have to maintain staff for emergency cases when there is no volume? Number 8. What is the staff turnover rate in our operating room? Number 9. What do the surgeons say about the competency of our surgery staff? Number 10. What resources have been invested to improve the maturity level of the surgery staff? Number 11. Are charged minutes or actual minutes used as the unit of service? And finally, number 12. If charged minutes are used, what are the time increments for charging? The answers to all of these questions should have an impact on the final standard that you develop for your operating room. Sterile processing. Depending on the age and configuration of a hospital, the responsibility for the sterile processing department can be delegated to materials management, surgery, central supply, or some other area. This has led to historical productivity standards that are generally based on the adjusted patient days, adjusted daily census, or some other measure of the hospital census. The problem with this measurement is that it has little bearing on the workload within the sterile processing area. The major work of the sterile processing department, or SPD, is the cleaning, decontamination, assembly, sterilization, and distribution of surgical and procedural instrumentation. While the census of the hospital may have some impact on the volume of surgical instruments, other factors include surgical case volume, surgical case mix, presence or absence of hospital-associated clinics, labor and delivery volume, and emergency department volume. The volume of patients or cases in these areas will determine the key workload unit of SPD, namely instruments. Typically, these instruments come as either a procedural tray with many items or a single packaged item, both of which require work to process. When items are sterilized, the contents of the sterilization load are documented either manually on a load card or in an automated instrument management system. This process makes it easy to track both the number of trays and packaged single instruments that are handled on a daily basis. In order to determine the amount of time that should be allocated to the processing of the instruments, it is important to determine all the steps that are associated with the processing of each tray of instruments. To determine this, ask yourself these questions. Number 1. How do the instruments get from the departments to the SPD area and who transports them? Number 2. What is the average time it takes to get a cart or tray of instruments to the SPD area? Number 3. What is the average number of trays per cart? Number 4. How long does it take to wipe down the cart? Number 5. What is the average time it takes to treat the trays and prepare them for the washer decontaminator? Number 6. Once processed, what is the average time to reassemble the trays and prepare for sterilization? Number 7. How long does it take to package a single instrument? Number 8. How long does it take to load the trays on a sterilization cart, and what is the average number of trays on the cart? Number 9. Who puts the sterile instruments away after sterilization, and how long does it take? And finally, number 10. Is the sterile processing function combined with hospital distribution? If so, can the two functions be split into separate departments in an efficient manner? By doing some time studies and answering these questions, you can determine an average time per tray and an average time per individual instrument. This will allow you to use trays processed and individual items processed as your units of service for your SPD area. Unless there is a significant change in the mix of cases within the procedural areas, the time estimates should hold true through the year. Procedures that require multiple loaner trays of high complexity, for example spine, total joints, complex neurosurgery, will impact the average time per tray for processing. If your SPD area is also responsible for the assembly of case carts, you should also factor in an average time for each case cart for all areas that are serviced. Having a realistic unit of service for the SPD area will ensure that the resources that are necessary to support the efficient turnaround of surgical instrumentation for the operating room will be present and allow the OR to run as efficiently as possible. Pre-operative assessment and preparation. In many hospitals, the preoperative assessment and preparation is broken down into 2 episodes of care. The first episode is usually an interview between the patient and a nurse to get a social and medical history, reconcile the patient's medications, and provide some preoperative teaching and instructions for the day of surgery. Typically, this is done at the hospital or over the phone, depending on many different factors. Patient portals through the hospital website are starting to be developed and will someday replace some of the data collection done by nurses. This first episode of care can vary greatly based on the needs of the patient and complexity of their current medical condition. Other factors that can impact the required time include patient language skills and age of the patient. Typically, this episode of care can be a 20-minute phone call or up to a 1-hour face-to-face assessment. Either way, whatever is not done during this first episode of care will get done in the second episode. The second episode occurs on the day of surgery. Typically, the patient is changed and prepared for surgery. A physical assessment is performed, an IV is started, any outstanding paperwork and/or tests completed, and all required documentation is verified. Patients may arrive approximately 2 hours before surgery. With nurse staffing at a ratio of 1:3, approximately 40 minutes of nursing time should be allocated to each patient. Post-operatively, the inpatients will go to the PACU, Post-Anesthesia Unit, and then their inpatient bed. The outpatients will go to PACU and then be returned to the preoperative area for a secondary recovery and discharge from the hospital. The patient will stay in the secondary area for approximately an hour, but certain procedures require the patient to stay on observation for several hours after surgery. This will be up to the physician and the hospital to determine. This area is usually staffed at a 1:3 ratio as well. There should also be time allotted for follow-up phone calls to physicians, review and assessment of any test results by the RN, and clerical time to assemble the patient record or check for completeness of the information. By adding up these times, we see that the pre- and post-process can take anywhere from 1.3 hours of nursing time to well over 2.5 hours. When developing the standard for this process, be sure to ask the following questions. Number 1. What percentage of patients are pre-assessed prior to the day of surgery? Number 2. What percentage come to the hospital versus are contacted by phone? Number 3. What are the demographics and cultural makeup of your patient population? Young or old, English-speaking or ESL, educational level, etc.? Number 4. What is the average amount of time spent to perform the pre-assessment process? Number 5. What percentage of your physicians are timely in providing orders, consents, and the H&P on their patients? Number 6. What is the typical ASA level of your surgery patients? Number 7. What is the case mix of your surgery department? Number 8. What percentage of your surgical case volume is outpatient? And finally, number 9. What is the average post-op length of stay for outpatients? By answering these questions, you should be able to develop a standard number of minutes per surgery patient. Post-Anesthesia Care. This unit is probably the most straightforward of perioperative units for establishing a productivity standard. When a patient first enters the PACU, they are usually emerging from general anesthesia. While in the emergence phase of care, the nurse-to-patient ratio is usually 1:1. This phase of the care can range from 5 minutes to 15 minutes or longer, depending on the type of anesthesia, the procedure, and the general condition of the patient. Once the patient has emerged, the nurse-to-patient ratio changes to 1:2 for the remainder of the time the patient is in Phase 1 recovery. Other factors that can impact the staffing in the area include the timing and the volume of the patient admissions to the unit, the acuity of the patients and surgery, the throughput to the nursing units for inpatients, the throughput to Phase 2 recovery for outpatients, and the transportation of patients to the nursing unit. Once these issues are determined, a standard in hours worked per minute of PACU time can be established. Now, we've considered the many different issues that affect productivity across the perioperative space, And we must remember that productivity cannot be determined in a one-size-fits-all design. Multiple factors across multiple departments are at play, and understanding the needs of each area will help you determine what the productivity standard should be for your facility. As always, thanks for listening to this episode of First Case Articles on the Go.